Today we're going to be talking about diabetes. We start with the diagnosis. Either a fasting glucose greater than or equal to 126, the use of an oral glucose tolerance test, or an A1C greater than or equal to 6.5%. For diagnosis, we would need to repeat these tests. Alternatively, if someone has a glucose greater than 200 and signs and symptoms of diabetes, they get the diagnosis. Management starts with lifestyle modification, working on diet, physical activity with the goal of weight loss. Also, managing comorbid conditions such as smoking and alcohol are necessary. The goal is to get someone's A1C less than 7%. When we do so, the risk of microvascular complications, including retinopathy, nephropathy, and neuropathy, is reduced. When we go above 7%, we find the risk of macrovascular complications, especially ASCVD, is increased. We want to monitor these. Yearly eye exams for retinopathy. Nephropathy, we check for microalbuminuria. And neuropathy, we do a comprehensive foot exam. When lifestyle modification isn't enough, we initiate pharmacotherapy. This diagram from the American Diabetes Association may seem complicated, but we'll walk through it and go step by step. The first step, in conjunction with lifestyle modification, is metformin. Metformin is highly effective, does not cause hypoglycemia, and is weight neutral if not allowing for some weight loss. It does have ASCVD benefit, and it's cheap. We do have to monitor, especially for people with kidney disease, as a GFR less than 30 is a contraindication and may increase our risk for lactic acidosis. Side effects are most commonly gastrointestinal, nausea, cramping, and diarrhea. We also have to monitor for B12 deficiency. The next step after metformin is asking whether someone has ASCVD or CKD. If someone has ASCVD, we should initiate one of the following GLP-1s or SGLT2s. Also, if someone has heart failure or CKD, we're also sticking with our GLP-1s or SGLT2s. Our SGLT2 inhibitors have intermediate efficacy, do not cause hypoglycemia, do allow for some weight loss, and as previously said, do allow some benefit in ASCVD and CHF. Unfortunately, these medicines are costly. We also have to know that there is a black box warning for increased risk of amputations, risk of DKA, Fournier's gangrene, and genitourinary infections and yeast infections. The GLP-1 agents, the injectables, are highly efficacious, do not cause hypoglycemia, do allow for some weight loss, and as previously stated, have some cardiovascular benefit as well as CKD benefit. Unfortunately, they are very costly. There is also a black box warning for increased thyroid disease, including thyroid cancers, as well as some risk for pancreatitis. Now, if someone is not at goal with metformin and they don't have ASCVD or CKD, we can use any of our agents. So let's look at the rest of them. The DPP-4 inhibitors are moderately efficacious, do not cause hypoglycemia, and are weight neutral. There's no benefit for ASCVD, CHF, or CKD. Unfortunately, these agents are also costly. There is some risk for acute pancreatitis. The TZDs are highly efficacious, do not cause hypoglycemia, but do cause some weight gain. They're cheap, there's some benefit with ASCVD, but there's increased risk for CHF, and there is a black box warning for this. There's also some additional considerations listed here. The sulfonylureas are highly efficacious, but they do cause hypoglycemia, and they do cause weight gain. There's not much cardiovascular benefit, nor renal benefit, but the medicines are cheap. Many times oral agents aren't enough, and we have to use insulin. We would consider it a first agent when there are acute complications of diabetes, such as DKA, need for rapid reduction of blood glucose, such as if someone's going to be having a surgery, if A1C is greater than 11%, considering greater than 10%, or if blood glucose is greater than 300. If there's symptoms such as weight loss, polyuria, or polydipsia, or we're trying to prevent end-stage complications, such as our microvascular or macrovascular complications. If we can't reach our A1C goal with 2 to 3 oral agents, we would also consider insulin. We would start with a long-acting insulin, and if we can't get the sugars under control, then we would add on prandial insulin. Additionally, we should make sure that we monitor everyone's hepatitis B status, and diabetics should receive the Pneumovax vaccine and get their age-appropriate screenings.